Hello there, this is Dr. Mintz. This is a 74-year-old female with sudden onset of chest pain and shortness of breath. I will give you a chance to look it over and see if you see anything abnormal, specifically something that could account for her history, her symptoms and signs. Okay, and we'll go back up here. So the first question to ask is there an abnormality? And here the answer is, of course, yes. And then to describe the abnormality, and to be able to do that, now you don't always have to go into those details, but in general it's a good skill to have to say, for example, here you see that there is something in this structure. So you hopefully know from my other lectures or other sources that this is the main pulmonary artery, and the right and left main pulmonary arteries branch off to that direction. So this is the main pulmonary artery, and if you follow it back, it comes from the right ventricle. So the right pulmonary artery goes off to the right, and the left pulmonary artery, a little bit higher, more superiorly positioned, goes off to the left, and there is something in them. How do we describe that? There are tubular or cylindrical filling defects extending into the right and left main pulmonary artery. In fact, it looks like a component of it is actually bridging across the bifurcation of the main pulmonary artery and extending into the right main pulmonary artery and the left main pulmonary artery. So that is a saddle embolus. So this is an embolus. This is pulmonary embolus. This is a life-threatening situation, potentially. How can we tell whether this is producing a severe effect on the patient at this moment or not? Well, there's something called right ventricular strain. And that means the right ventricle is having difficulty emptying out its entire content. So if you look at the size of the chambers, the right ventricle here is large compared to the left. And that sometimes is reflected in this interventricular septum right here being displaced toward the left ventricle, because the left ventricle is pumping into the aorta and it has no problem emptying its content out. But when the right ventricle has difficulty because of embolic material, thrombus, blood clots in the pulmonary arteries, then it cannot empty as fully, so there gets to be a backup of volume in the right ventricle, and that leads actually to a displacement of the interventricular septum to the left. And that indicates that there is a component of strain, that the right ventricle is straining in order to get its blood ejected fully. And that has prognostic significance. Okay, so that's right ventricular strain. That is an important thing to tell the clinician. They appreciate it because it means that the pulmonary emboli, which do not always create an immediate emergent patient condition, that in this case it is producing an immediate and emergent clinical condition, because we can see this right ventricular strain. It just cannot empty out quite as much as it'd like. Okay, and we have these tubular filling defects. Why are they tubular like this? They're tubular because they are casts of our leg veins. Almost always, these are blood clots that have formed in the legs. The saphenous vein, femoral vein, any of the venous structures can produce clots, and it's the deep venous structures that are most susceptible to release them once formed and create pulmonary emboli. And that track, of course, is very simple. You know that the inferior vena cava carries those blood clots up to the right atrium and then the right ventricle and then out through the pulmonary outflow tract into the main pulmonary artery. And that's right here. And that is in the right main pulmonary artery there. And you can see the clot there. And the left pulmonary artery here. This is the arch of the azygos vein, which is a systemic vein that empties up through the azygos vein here. Actually, in this case, this is the hemiazygos. The hemiazygos vein is coming from the left side and crossing over. So that's just a kind of interesting anatomic variant. Here's the trachea, and this is the bifurcation of the trachea into the right and left main stem bronchi. Here is the ascending aorta going superiorly to give off the brachiocephalic artery, the left common carotid artery, and then the left subclavian artery. And this is the subclavian vein, which was the site of injection, which is why it is so densely enhancing. Okay, the cardiac chambers I think we know well. This is the left atrium emptying into the left ventricle and the aortic outflow tract. Here's the SVC coming down into the right atrium. Okay, that is pulmonary embolism with a saddle embolus and right ventricular strain.